Hello and welcome to a continuation of our lecture on Chapter 38, where we're going to continue talking about the musculoskeletal system. In this video, we are going to cover Section 38.3 on joints and skeletal movement. And our learning objectives are to classify the different types of joints on the basis of structure and explain the role of joints in skeletal movement. So first I want to clarify what is a joint, or sometimes we call it an articulation. And this is a point where we're going to have two or more bones meet, and it's responsible for the movement that takes place there, such as the movement of the limbs like we see over here, and stability. And we find a lot of stability within the bones of the skull, whereas in areas like our shoulder or our hip, we are going to have a little bit less stability because we have greater range of motion. Now let's do an overview of how we classify joints. And so we really classify it in two different ways. We have a structural classification and a functional classification. So with our structural, we are really focusing on the material that's composing the joint and the structure of what it is. And so we classify it as a fibrous joint, meaning that it's held together with dense connective tissue. Cartilaginous joints mean that the bones are joining by some type of cartilage, and a synovial joint means that the bones are joining together by ligaments and a fluid-filled joint cavity that separates the bone surfaces. When we look at a functional type of classification, we're looking at the movement that is taking place at the joint. So we classify them as synarthrosis, which is really where our immobile joints are. So we really don't have a lot of movement taking place here, and it could be either a fibrous or cartilaginous type of joint as far as the structural classifications. And then in the middle, we have our amphiarthrosis joints. So this means we just have a slight mobile joint, and this could be, again, fibrous or cartilaginous. But if we have a functional classification of diarthroses, that means that this joint is freely movable, and this will consist of all of our synovial joints. So we're going to first start talking about our structural classification, with fibrous joints being first. And the characteristics are going to be that they are connected with dense, regular connective tissue. There is not a joint cavity, and we know that these joints are either immobile or just slightly mobile. And we have three common types: gomphoses, sutures, and syndesmoses. So let's take a look at those types or subtypes next. But before we do that, I just want to let you know that this is a histology image of what dense, regular connective tissue looks like. So this is what sits between the two bones. So first we have our sutures, and we find a lot of these within the skull here. So we will have short fibers that will connect these like interdigitations of bone or interlocking irregular edges of bone to pull them together. And this is going to increase stability and also decrease our risk for fractures. They function as synarthroses, meaning that they are immobile. And what's good is that it allows us to have growth in childhood. So if you remember from our previous sections, we talked about those fontanelles and how we were going to have a little bit more of a membranous type of tissue in between these bones, but eventually they will turn into this dense connective tissue and form sutures. All right, next we have syndesmoses, and these are bound by something called an interosseous membrane, which is a broad ligamentous sheet. So let's break that word down. Inter means between, osseous means bone, and membrane, of course, is just a membrane, so like a flattened sheet here. So we find this between our two bones in the forearm, right along in here, and we would also find it between our two bones in our leg, our tibia and our fibula, and these joints function as amphiarthroses, meaning that we're going to have just a slight movement, so it allows us to have pivoting of these two bones. You don't see it in this picture, but the forearm is in a supine position, so if you were like holding a rock in your palm of your hand, that's supine position. And if you were to then turn your hand and throw that rock on the ground, then that is pronation. And when pronation takes place, we're going to see this radius bone cross over the ulna. And so this interosseous membrane is going to kind of help guide and stabilize that movement. Then we have gomphoses, and this is a peg in socket, meaning that we've got an articulation of these teeth within the sockets of here, the maxilla, and within the sockets down here in the mandible. So the tooth is held in place. We don't see it pictured here, but there's these periodontal membranes that would kind of encircle this area here. And they're going to function as synarthroses, meaning they are immobile. We don't really want our teeth to move too much, unless of course we're using braces, but you know that takes time, right? They're not going to move very easily. And when we lose teeth, we start to lose some of these periodontal membranes so that the tooth can fall out. All right, the next major classification for structural classification is the cartilaginous joints. And our properties here are that it's made up of either hyaline or fibrocartilage. So I put pictures of what these two tissues look like over here. You could see that with our fibrocartilage, we do have really thick collagen bands in here. With this joint, we're not going to have a joint cavity, and the movement is immobile or slightly mobile. And so they are going to be subclassified as synchondroses or symphyses. Notice that these words are different than our functional classification that we saw here of synarthroses, right? So we'll start off with the synchondroses. Chondro means cartilage. And so these types of joints will have hyaline cartilage between them. So you could see here in the epiphyseal plate, we have some hyaline cartilage within the bone. We're going to talk more about this in the coming section, or sorry, this was in section 2 that we discussed. And then over here, we have our hyaline cartilage attaching our rib anteriorly to our sternum. And this is immobile. The other subclassification is symphyses, and this is going to be a pad of fibrocartilage. So we could find it either here between our two pubic bones, and that is called our pubic symphysis, or we find it making up our intervertebral discs. So sitting in between the vertebral bodies here, and it assists us with resisting compression and acts as shock absorbers. So we just have slight mobility here, making it ampiarthroses. When we do things like, let's say, a lateral flexion, it kind of allows our spine to move around. The pubic symphyses is only really going to move during childbirth. It's going to relax and allow the hips to kind of move away from one another as the fetus or baby moves through the birth canal. All right, and that brings us to synovial joints. These joints are going to have a joint cavity. So you could see that pictured over here, and it's going to include most of our joints within our body. And like we said before, functionally, they are diarthroses, meaning they are freely movable. And all of these will have these basic features. First, we have an articular capsule. So that is this right along in here, that fibrous portion. We also have an inner portion that I'm going to talk about in a little bit. Inside of it, we're going to have a synovial fluid. And then lining each of the bones, we're going to have an articular cartilage, which is made up of hyaline cartilage. And we'll have ligaments. They could be inside the joint or they could be external to the joint. We'll have some nerves associated with it and blood vessels. So let's talk about that articular capsule again. Like I said, there's two layers. There's a fibrous layer, and this will help to strengthen the joint and prevent the bones from being pulled apart. And the inner synovial membrane is important because it is going to help produce synovial fluid, which is within the cavity. And this prevents any friction from taking place, so really lubricates the joint. And then I mentioned the articular cartilage is made up of hyaline cartilage, and it is also going to reduce friction during movement. It creates a cushion to help absorb compression and prevents damage to the articulating ends of our bones here. Now, this is avascular, so meaning that we don't have blood vessels within the articular cartilage, so it takes a long time to heal when it's damaged, and we're going to get our nutrients through diffusion by nearby blood vessels. All right, so now let's go through the subclasses of our synovial joints, and that is going to include a plane joint, hinge, pivot, condylar, saddle, and ball and socket. So let's take a look at those first three. A plane joint is when we have bones that have flat surfaces. It's our simplest, least mobile synovial articulation. We say that it's uniaxial, meaning it's only really moving within one plane, and it moves a bit more side to side, almost like a gliding type of movement. A hinge joint is going to be when we have a convex surface with a concave depression. So we see it's almost like a hinge on a door. And an example of this would be in our elbow joint, where we have an area called the trochlea. Trochlea is over here, and it fits against the trochlear notch here in the ulna. And we also say that this is uniaxial because we're only going to have movements called flexion and extension. Then we have our pivot joint, which is going to be when we have a bone that is rounded and it fits into a ligament ring. So that is pictured over here. We have a little depression here in the ulnar bone, and then the head of the radius here is very round, almost like a hockey puck, and it just fits right in. And then we have this ligament called the annular ligament that holds it in place so that this radius bone can rotate and turn within it. And this is also going to be classified as uniaxial because we're only rotating on a longitudinal axis. Our next three include the condylar joint. And our condylar joint is going to have a oval convex surface that articulates with a concave surface. So an example of this would be like our metacarpophalangeal joint. I know that's a mouthful. So metacarpo is referring to our metacarpal bone here, and phalangeal is referring to the first, or I guess most proximal phalanx that we have over here. And we would call this biaxial because we are able to flex and extend an abduct and adduct. And then we have our saddle joint, which is going to be made up of a convex and concave surface that looks like a saddle, hence the name. And so an example of this would be our carpometacarpal joint, where we are going to see a biaxial movement. And again, we can flex, extend, abduct, and adduct over here. And then lastly, we have our ball and socket joint, where we will have a spherical head of one bone that fits into a cup-like socket of another. And so we could see this in the area of the shoulder. We can also see it in the hip. Let me kind of go back to that we had it here in the beginning. Right here, where we have what we call the head of the femur fitting into the acetabulum of the hip bone. And as you saw from that movement of the hip, it is multi-axial, meaning that we have movement in 3 planes. We can flex, extend, abduct, adduct, and we also have rotation taking place along the longitudinal axis. And these are the most freely mobile types of joints we have within our body, which means that they are the least stable. So let's talk a little bit more about the movements. And so we are going to focus more on the functional classifications here, even though I kind of trickled those in as we were talking about the structural classifications. But next, we're going to focus more on what those movements are. So we'll cover gliding, angular, rotational, and some special movements within specific joints. So first is gliding, where we're going to have two opposing surfaces sliding back and forth or side to side. This is going to take place in the area of the foot. These are called our tarsals, which are similar to the bones within our wrist, which are called carpals. And so these are plane joints, which are synovial joints. Then we have our angular motion. This is actually going to increase or decrease an angle between two bones. So we have a couple different movements. First, we have flexion and extension. So at the elbow here, if we are making this angle smaller, we are going through flexion, so this position here. Whereas when we bring it down and make that angle larger, it becomes extension. We could see the same thing over here with the head. When we flex at the neck, we're bringing it forward, and when we pull it back, that is extension. We could see it taking place here at the wrist and the knee joint here, where we are flexing, this angle becomes smaller, pulling it back down, making that angle larger. And then we have lateral flexion when we bend over to the side. And then here are just more specific examples here. I think I covered most of these, so I'm going to bypass this a bit quickly. Sometimes we can have hyperextension. So for example, at the shoulder here, when we bring our arm up in this direction, so bringing it up in front of you, and then pulling it all the way up, that's going to be flexion. Whereas when we bring it back down, it's extension. If we were to continue and move that arm further back, like we see pictured over here, that is called hyperextension, meaning we're beyond what the normal anatomical position is of that limb. And then lateral flexion here we said is going to be when we bend over on our side, and that is taking place within our coronal or frontal plane, and it's really in between our vertebrae in the cervical and lumbar regions. Now for abduction and adduction. We pronounce this as abduction and adduction, but I pronounce the B and the D just to be a little bit more clear. So with abduction, it's when you take that limb or structure of your body and you're going to pull it away from the midline. So I always think you're being abducted away from planet Earth. You could see that taking place here in our lower limb as well as we lift the leg away. And then in our hands, abduction is going to be when you spread your fingers apart, whereas when we're talking about the wrist, it's going to be when you pull your hand on the thumb side closer to your forearm. So that's abduction there. With adduction, we are just bringing that limb back down. So we are adding it to your body toward the midline. So if we look at it in your wrist, you could see that we're going to take that pinky side now and move it toward the forearm. And in your fingers, it is when we pull our fingers together. That's called adduction. And then lastly, with our lower limb, pulling it back into the midline. And when we add all four of those movements, flexion, extension, adduction, and abduction, it is called circumduction. So it's when we have this circular movement of our arm or our limb, and we're essentially making an imaginary cone shape as we rotate that limb around. Now let's talk about rotational motion. When we have rotation take place, typically we're going to have a bone that pivots on its own longitudinal axis. So we have lateral rotation, and you could see that over here where we're going to turn that anterior surface of our humerus laterally or toward the outside. And sometimes, especially in physical therapy, this is called external rotation. Now, the opposite of that is going to be medial rotation, where we take the anterior surface and turn that bone medially or toward the inside. So this is commonly called internal rotation as well. Now, we also have specific movements that take place around our forearm. So first we have pronation, and this is when you are looking at the back of your forearm and the back of your hand. And in order to get it into this position, we need to do what's called medial rotation of the forearm to turn the palm of your hand posteriorly or toward the back. Whereas if we were to flip our hand around and have our palm facing out like this would be called supination. Almost like if you were to flex at the elbow and be holding a bowl of soup. To remember that, you would be in supination. And notice how this is a lateral rotation of that forearm. Next, let's talk about some special movements that really aren't going to fit the other functional categories. So, for example, we have the terms depression and elevation. Now, this can take place regarding our mandible or the scapula, like you see pictured here. When we have depression, we're pulling the scapula down, almost like we're really pulling our shoulders down. And so it's an inferior movement of that body part. We can do this with our mandible or our lower jaw as well by opening our mouth. And when we lift our mouth up to close our mouth, that is that superior movement that we call elevation. We can also elevate our scapula by shrugging our shoulders, and that lifts our scapula up closer to the superior end of our body. Now, if we focus on the foot, we have dorsiflexion and plantar flexion. Dorsiflexion is going to take place at our talocrural joint, also known as our ankle joint. So talo is referring to the talus bone, which is a tarsal in the foot, and crural means leg. So it's the point where the leg joins that talus. And so we are going to bend so that the dorsum, or the top of the foot, the superior surface, is moving toward the leg. Whereas if we are pointing our toes down, this is plantar flexion. And we are going to feel like ballerinas on our tippy toes when we are in full plantar flexion. Also, regarding the foot, we can do eversion, where we are going to take the outside of our foot, so the lateral aspect of our foot, and raise it up so that our sole of our foot is turning laterally. And this is really taking place in our intertarsal joints, so the joints between the tarsal bones in the foot. And then we have inversion, where we're going to take that medial aspect of the foot and turn it upwards. Now let's cover the terms protraction and retraction. Protraction can refer to the scapula when you are kind of rounding out your back. So this here is showing us protraction, whereas when we retract, you're bringing those two scapula together. Your shoulder blades are coming together. Sometimes we call this abduction of the scapula and adduction of the scapula. Now, we can also have these two terms used when we talk about our jaw moving at what's called the temporomandibular joint. Temporo, because our temporal bone is here, and mandibular, because the mandible is going to insert into a special spot on the temporal bone. We'll leave it at that to keep it simple. And so when we shift that mandible forward, this is called protraction. And when we pull our jaw back, it's called retraction. Lastly, we want to talk about the fingers here and our ability to oppose our thumb. So what that means is we are able to take our thumb and bring it over to our other fingers. So we can bring it over to the little finger at our carpometacarpal joint. The carpometacarpal joint is where the carpal is meeting our metacarpal bone. And then we are able to grasp objects in this way. We can also take our thumb and bring it over to our fourth digit, third digit, and second digit. Reposition is just when we are moving that thumb back into its original position.